I'm a medical oncologist from Vilnius University Institute of Oncology, and I'm specialized in GI cancer, especially in colorectal cancer, and have many practice in it. And today, briefly, I will show the situation in Lithuania. At first, we have about 3 million population in Lithuania, and there are 6 medical centers that provide specialized care for cancer patients. So we have 2 centers in Vilnius. It's our institution and Santariškių Clinics institution. There they have only surgery and chemotherapy. They don't have radiation therapy there. Then we have a big center in Lithuanian University of Health Science, Kauno Clinics Hospital. They have all the opportunities to cure all the, mostly all the kinds of treatment. Then we have Klaipėda University Hospital, Republican Šiauliai County Hospital, and Republican Panevėžys County Hospital. So it covers mostly all Lithuania. And most common cancer types in Lithuania are prostate cancer. You see, in 2011 it was 2,700 of this kind of cancer. Then we have skin cancer, and colorectal cancer is in the 3rd place, and we have more than 1,600 patients on 2011. Then we have breast, lung, and other type of cancers. And this slide you saw earlier, and annual growth of colorectal cancer each year is from 3 to 6%, and colorectal cancer is 2nd most common cause of death across all the types of cancer. And of course, early diagnostic, early detection is the key point of the problem, because as we know, the stage is a major prognostic factor of colorectal cancer. Well, in 2009, I am showing a statistic in 2009 because, as you know, about 45% of cases, widespread disease or locally advanced disease is diagnosed in Lithuania. And we see only 10% we had stage 1 disease, and 27% stage 2. Only 19% there were not reported what kind of stage it was diagnosed. So that was the problem, that we see that with this such a big amount of extended disease, we cannot have very good results in treating this. That's why in 2009 we started a prevention program in Lithuania also. And as you see, this reflects in survival. Stage 1, 5-year survival, we have 81%. For stage 2, 67%. Stage 3, 48%. And unfortunately, 5-year survival of stage 4 disease, it is only 6%, and it's very sad. Those numbers are very sad, and overall 5-year survival is only 45%. And our aim is to change those numbers. So about the screening program of colorectal cancer, its purpose to early colorectal cancer detection. And so by increasing early stage detection, we can decrease mortality rate. And it is based on testing of EFOP test from fecal occult blood testing, and then to colonoscopy. And it started at 2009. And we think that 6 out of 10 lives could be saved if people regularly perform testing after they run 50 years old. So unfortunately, but this program covers only 2/3 of Lithuania. It doesn't exist in all the parts of Lithuania. We have 10 districts, and only in 4 districts it is going on. Well, why? Because there are some problems with colonoscopy, like an administrative program, so we are working to expand this program. And we invite men and women from 50 to 74 years old once every 2 years to perform EFOP test. and they are invited by GP, general practitioners. And if EFOP test is negative, they are invited after 2 years. If it's positive, they are referred to colonoscopy. And if colonoscopy is negative, they can be invited for EFOP test only after 10 years. And if the condition is discovered, the patient is referred to a specialized center for biopsy and other procedures. Well, of course, I cannot say the correct of how the screening program is going on, but there are some problems. We don't cover all the Lithuania. We don't have a like coordinating center of screening program because every district work by each other. So we are working on to get some coordinating center to make the screening program more effective. But in our institution, we also see that by the start of this program, we see more and more stage 1 cancer patients that can be cured by surgery. Well, when we talk about diagnostic, in all the major centers, when we talk about radiological diagnostic, we have all like major diagnostic like colonoscopy, ultrasound, radiology, CT, MRI, we have in those centers. But what we don't have is PET-CT because it's available in mostly countries in European Union, and it is like widely used for colorectal cancer diagnostic. But in Lithuania, unfortunately, we have this scan, but it is not reimbursed for colorectal cancer patients. Treatment options. All of them are available in Lithuania, but not all in all the centers. So when talking about the surgery, we're working for specialized surgery. So we are trying to make the cancer surgery be made only in specialized centers. So those small hospitals should not operate on cancer because they would not do an adequate operation or adequate diagnostic and adequate treatment. So surgery is mainly concentrated in 4 high experience centers, and we do all the multiple liver resections, lung resections, and they are made only in 3 centers. We have a HIPEC, it's hyperthermic intraperitoneal chemotherapy for colorectal cancer, gastric cancer, and ovarian cancer, which is spread in peritoneum, and it can be made in 2 centers in Lithuania. When we talk about radiotherapy, it's also part of the treatment. We have 4 centers that can make this treatment, and we have new techniques. Unfortunately, the stereotactic technique is not available in Lithuania yet. When we talk about regional treatment options, we do this. We make radiofrequency ablation in 3 centers, chemoembolization in 3 centers. We started in our center radioembolization, intraarterial chemotherapy, and all this helps to do the best for our patients. And when talk about systemic treatment, all those 6 centers can conduct this systemic treatment, and we have chemotherapy and biologic therapy. And we are a multidisciplinary approach. We are trying to achieve that all the primary patients should be discussed. All this treatment plan should be made in multidisciplinary team in order to achieve the best results. When talking about the chemotherapy, we, like all the main drugs are available without major limitations in Lithuania. The older ones like Favipiravir, Leucovorin, Capecitabine, and Tegafur is included in reimbursement list and no limitation for use. The newer ones, Irinotecan and Oxaliplatin, they are annually purchased by National Health Insurance Fund, and amounts are like, I think they are sufficient, more or less they are sufficient, and no limits for colorectal cancer treatment. When talking about biologic therapy, which is the standard of care in Europe, as we heard earlier, our National Health Insurance Fund has been started purchasing this bevacizumab since 2006 and cetuximab since 2011, but we still have major limitations. When talking about bevacizumab, it is reimbursed only for first-line colorectal cancer treatment until progression. We know that it has been shown that it's effective in the second line and when treating beyond progression, but unfortunately we don't have these options in Lithuania. When talking about cetuximab, we know that it is effective for KRAS wild-type patients, but in Lithuania we have only this drug for induction therapy for KRAS wild patients with liver-only potential resectable metastases, in order to give this very expensive treatment, which shrinks metastases very quickly to become resectable and resect them. And no possibility to treat patients with extrahepatic disease or to treat in second and further lines. In further lines, we know that in third line, this drug is very expensive, very effective, but we don't have any option. And for panitumumab, we don't have this drug in Lithuania. So the limitations also are because of lack of funding and saving policy, we need the need of biologics is covered only approximately 30% of first-line colorectal cancer patients. So we are in a very bad situation because, of course, we have drugs, but how can I choose one patient from 3 that I will give to you or to you not? It is a very difficult question. Of course, we are looking for better condition, young patient and so on, but it's very difficult to choose which patient to treat and which not to treat. It's also the rights of patient are not good to live. So, and we have a National Health Insurance Fund tender, and in 2012 but it was not realized as it was said, and at the present moment we still are waiting for 2013 year tender, and in present time we are partial purchases performing, and in some centers we have saving policy, the patient number or treatment duration limitation. In some centers they treat patient with bevacizumab for 1 year and then stop, when clinically it's not wise because it should be treated until progression. So everybody's trying to make something from the situation. And the most bad news is that recent restriction now we have a restriction to stop bevacizumab for new patients. Now, if I have young and fit patient, I cannot start bevacizumab because our National Health Insurance Fund now it has written embargo to stop, and we cannot start. So we have biologics, but since we have a very big limitations and we are not satisfied with this situation. And as you know, in Lithuania we don't have a colorectal cancer patient organization. Thank you. And I think that our patients also should be aware of the situation, and they should be more active to help us to get this treatment for them. And thank you very much.